Okay, shall I start
Yes,
now?
we can.
Yeah. Good evening and a very warm welcome to one and all. I, Dr. Ganvi, on behalf of the Indian Thyroid Society, invite you to another episode of the Wednesday special Thyroid Clinics. So before we start, let us briefly go through the activities of the Indian Thyroid Society. So Indian Thyroid Society was established and registered in 2003. It's a national body of healthcare professionals with special interest in thyroid disorders. Endocrinologists, endocrine surgeons, nuclear medicine physicians, general surgeons, and ENT surgeons are part of Indian Thyroid Society. It is a member of the Asia Oceania Thyroid Association, that is IOTA. ITS currently has nearly 2,000 members. So the executive committee has Dr. Professor R.V. Jaikumar sir as the founder president and our current president, Professor Sarita Bajaj madam. Also in that executive committee, we have past president, Professor Rajesh Rajput sir, secretary, Dr. Arun Menon sir, treasurer, Dr. Mini ma'am. Also in the executive committee, we have the vice president, Dr. Himagirish K. Rao sir, our scientific committee coordinator, Dr. Pramila Kalra madam, and joint secretary, Dr. Sujay Ghosh sir. Dr. Shashank Joshi sir, Dr. P.K. Jabbar sir, Dr. Krishna Sheshadri sir are all members of the executive committee. Dr. Mohammad Riyaz sir, Dr. Sushil Gupta sir, and Dr. Ashraf Jani sir are also members of the executive committee. So the aims of the Indian Thyroid Society is to organize academic activities for healthcare professionals, to promote public education and awareness about thyroid disorders, to encourage research in thyroidology, to encourage publication in the flagship journal, that is Thyroid Research and Practice. So it has state-of-the-art publications and it awards fellowship of the society as well. ITS also encourages membership of the society. So the ongoing academic activities by the Indian Thyroid Society include CMEs, updates, symposia, and conferences. So the thyroid clinics, which were initially held weekly and then fortnightly, is now being conducted monthly. So there is journal club, case conversations, monologue, geologue, panel discussion, meet the professor session, quiz, workshop, and CPCs included in these thyroid clinics. So Indian Thyroid Society also celebrates the Thyroid Awareness Week from May 22nd to May 28th. Also, World Thyroid Day is celebrated on May 25th. So Thyroid Awareness Month is celebrated annually in January. So the research activities undertaken by the Indian Thyroid Society includes, it provides annual grants for original research studies focused on thyroid and related disorders, preferably in the Indian context. Research grants are available, and to apply, the details can be accessed through the website, that is indianthyroidsociety.in. So coming to the flagship journal of Indian Thyroid Society, that is the Thyroid Research and Practice, which is published twice a year in print and online. It has a quick turnaround time. Electronic copies are available ahead of print. So also Indian Thyroid Society awards fellowship. It is basically awarded to the ITS members with expertise and experience in the field of thyroidology. So the fellowship will be selected by an expert panel, and the eligible members will be conferred the Fellow of the Indian Thyroid Society. So textbook is also being published by the Indian Thyroid Society, that is the ITS textbook of thyroid disorders, editors of which are Dr. Sarita Bajaj madam and Dr. Rajesh Rajput sir. Also, there are multiple other publications and guidelines which are being published by the Indian Thyroid Society. So the latest guideline is the Thyroid Disorders in Pregnancy Consensus Statement of Indian Thyroid Society by Dr. Rajesh Rajput sir, Dr. Sarita Bajaj madam, Dr. Sujay Ghosh sir, Dr. Pramila Kalra madam, Dr. Arun sir, and Dr. Mini ma'am. It is published in the Thyroid Research and Practice 2023. So the upcoming guidelines include management of subclinical hypothyroidism, which has been sent for publication, and also thyroid nodule. So other guidelines published by the Indian Thyroid Society include guidelines for the management of dyslipidemia and thyroid dysfunction, hypothyroidism and diabetes, guidelines for the management of depression and thyroid dysfunction. So we are celebrating we are conducting, the Indian Thyroid Society is conducting the annual conference in Kochi this year. That is the ITSCON 2023 on 27th and 28th of May. So also there is a thyroid ultrasound workshop conducted on which will be conducted on May 26th. Esteemed distinguished faculty Dr. Susan Mandel sir, ma'am, and Dr. Krishna Sheshadri sir will be conducting this workshop. Also, there is a symposium on the recent advances on thyroid cancer on 28th of May between 8:40 to 10 o'clock. Dr. Vagesh Iyer sir, Dr. Sadish Kumar sir, Dr. Pinaki Datta sir, and Dr. Roma ma'am will be discussing regarding this. Also, there is a surgeon symposium which has two panel discussions, one on the perioperative management of thyrotoxic patient and postoperative hypocalcemia, which will be conducted on May 27th. Also, there is the Thyroid Mastermind Quiz, which will be conducted on both 27th and 28th of May, with attractive prizes for the quiz winners. So that is about the ITSCON 2023. So Indian Thyroid Society also has its own website, the contents of which include the link to guidelines, access to ITS journal, records of all the academic events, and also the online membership portal. So the membership will be awarded to all the MCI registered modern medical practitioners in India. There are two types of life membership. The amount is about 2,950 rupees, full-time life membership as well as associate life membership. So full-time life membership is awarded to the specialists in the field of endocrinology, endocrine surgery, and nuclear medicine. Associate life membership is for all the other registered medical practitioners. So the membership is, the applications are available online on the ITS website, which can be accessed through the link that is the indianthyroidsociety.in. So without further delay, we will be going to our webinar now. Basically, the thyroid clinics, Wednesday special thyroid clinics organized by the Indian Thyroid Society is conducted under the leadership of our four conveners, Dr. Sarita Bajaj Madam, who is the president of ITS, Dr. Pramila Kalra Madam, who is the scientific chair of ITS, Dr. Mini Ji Ma'am, who is the treasurer of ITS, and Dr. Arun Menon sir, secretary of ITS. So today's session, we have Dr. Neeraj Agarwal sir, our esteemed chairperson, Dr. Sandeep Mathur sir as our moderator, and we have two journal presentations by Dr. Tharu Gupta and Dr. Supreet Chandrasekhar. We also have a quiz by Dr. R. Santosh sir in between. So without further delay, we will just discuss regarding the quiz participation rules. To participate in the quiz, having the Zoom app on the mobile device or laptop is essential. You are requested to use a laptop for the ease of experience. The quiz will run for 10 minutes. There'll be first two dummy questions followed by the actual quiz. The quiz master will display the case or description of the quiz by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All the 10 questions will be available when the poll is launched, and answer for all the questions should be submitted at the end of 10 minutes. To read the case or description, you can close the polls option using the X button and again use the polls option to answer the respective question. So we shall have, okay, so we will go to the webinar now. So we have our esteemed chairperson with us today, Dr. Neeraj Agarwal sir. So can we have Sir CV? Yes. Sir is the Associate Dean of Research at IMS BHU, and also Sir is the Professor and Head at the Department of Endocrinology at Metabolism at IMS BHU. Sir has been awarded the Nodal Officer of that is the Regional Resource Center of Telemedicine at IMS BHU. So I would request our esteemed chairperson to carry forward this session. I request Dr. Neeraj Agarwal sir to introduce the moderator, Dr. Sandeep Mathur sir. Over to you, sir.
Good evening, everybody. I thank the Indian Thyroid Society for giving me the privilege of chairing the session of this journal club, and I giving the privilege to introduce our senior member, Professor Dr. Sandeep Mathur. He is senior professor and HOD of endocrinology of a prestigious medical college, that is SMS Medical College. He is in charge of the molecular genetics research lab, a very prestigious lab of the genetics in endocrinology. He is a MD DM endocrinology from AIMS, and he has an area of interest in molecular genetics of hormone and metabolic disorders. He is the greatest achievement by him is he has been very eager and very active researcher in the field of genetics of endocrinology. So he is recipient of Commonwealth Academic Staff Fellowship, Travel Award by ACE, Merit Award by Government of Rajasthan, several other awards like Times of India, Economic Times Achiever Awards, and he is editorial board member in Frontiers of Endocrinology, Handling Editor, Special Collection, Associate Editor in International Journal of Diabetes in Developing Countries, and IJEM. So that is the National Journal of Endocrinology. So with this, I invite him to conduct the today's journal club. Sir, you are muted.
Thank you, Neeraj. Sorry. Good evening to all of you, and it's really a pleasure for me to participate in this journal club. And thanks to the Indian Thyroid Society for this opportunity to look into those two very important articles published recently, and their implication not only the message of those articles, they have more applications and further direction of research in our country. Because whenever I go for any journal club or any meeting, I always look what can we do in our country, what is the new or upcoming areas of investigation, or what are the clinical problem for which we need some answer. So today we have two. Screen has gone. Today we have two presenters. Fortunately, both them are student. I always say doctoral student. Actually, we say our DM student. I say is more appropriate with doctoral students, because MD means he's like PhD. And somebody is pursuing is clinical research or academic research or even basic research or clinical practice research, I would say. I will call such student or trainees as a doctoral students. So Taru is in second year with BHU, and I have Neeraj knows how I am associated with BHU because JK sir, I had my training with him. Two things I learned from BHU. Number one is the endocrinology, a good clinical endocrinology. The second thing I learned, Neeraj, from JK sir, how to become a good human being. So, and how to become a good teacher. So two things I additionally learned from BHU. So over to Dr. Taru. And what she is going to speak some very, thyroid autoimmunity and your pregnancy and your, perturbation during pregnancy, and what happens afterwards. Something very interesting article in this field. Over to Dr. Taru.
Hello, am I audible?
Yes.
You are audible.
Good evening, respected faculty members and all my dear colleagues. Today, I'm Dr. Taru Gupta. Will be presenting a very important journal article that is published recently in Journal of Clinical Endocrinology and Metabolism. That is evaluating the progression to hypothyroidism in preconception euthyroid thyroid peroxidase antibody positive women. The study was done by Sophia Gill. It was conducted in United Kingdoms. Introduction. The TPO antibody are the pathognomic and autoantibodies found in Hashimoto thyroiditis, which is present in almost 10 to 15% of biochemically euthyroid women. Higher TSH and lower free T4 concentrations found within normal ranges in these TPO positive women. TPO positivity has been linked to adverse pregnancy outcomes. Various similar studies have been done in past, like the tablet trial, postal trial, and T4 life trial. This journal club that I'm presenting today is the secondary analysis of the tablet trial. In the general population with TPO antibody positive state, the rate of increased preponderance of developing thyroid disease is about 3 to 41.67% in longitudinal studies. So to improve pregnancy outcomes, efforts should be made to prevent progression to overt or subclinical hypothyroidism. The aim and objectives of my study, this study, is to establish the rate of development of hypothyroidism pre-conception and during pregnancy in an initially euthyroid TPO antibody positive population. To compare the secondary objectives are to compare conception and live birth outcomes in women with treated hypothyroidism and those who remain euthyroid, and to determine the rates of iatrogenic thyrotoxicosis in those taking levothyroxine 50 micrograms. The methods of this study includes the eligibility and recruitment setting that were the women of 60 to 40 years of age with who are actively trying to conceive in the subsequent 12 months with history of miscarriage, previous miscarriage or subfertility, and those are biochemically euthyroid with TPO antibody positive status and not currently receiving any treatment for thyroid disorder or taking amiodarone or lithium. For TPO antibodies, a range of assays were employed and the quality assurance was done by the immunohistochemistry, immunology, and allergy of national quality assurance in UK. The euthyroid eligibility criteria that was taken was TSH values of 0.44 to 3.63 milli international unit per liter and free thyroxine levels of 10 to 21 picomoles per liter. Then following randomization to randomization to levothyroxine of 50 microgram and placebo, the participants were followed up to 12 months of age with regular TFT monitoring at an intervals of 3 months and 6 months. If there was the diagnosis of clinical pregnancy in between, then thyroid profile was assessed further at 6 to 8 weeks of gestation, then 16 to 18 weeks of gestation, and 28 weeks of gestation. These were the thresholds used during during the monitoring for identification and categorization of subgroups of thyroid condition. In this, various assays were used for the measurement of free T4 and TSH. So in pregnancy, the range that was taken for the T4 was in the first and second trimester, it was 10 to 22 by Abbott and 10 to 25 by Roche method. And in the third trimester, it was 10 to 18 by the Abbott and 10 to 20 by the Roche method. While for the TSH, the values that were taken as normal were 0.44 to 4 by the Roche method and 0.44 to 3.5 by the Abbott method. Participant withdrawal. Patients with abnormal thyroid profile according to the previous table were withdrawn and they received necessary treatment as per the local guidelines. The outcome data was also collected for these patients as this was an intention to treat analysis. The subclinical hypothyroid patients they were not all withdrawn. They were treated as same as euthyroid women and allowed to continue on the trial drugs. Outcomes. The main outcome of interest in this study was the development of abnormal thyroid function, and the other secondary outcomes were number one, failure to conceive within the 12 months period of randomization, then pregnancy loss, live birth at or beyond 34 weeks of gestation, maternal and neonatal complications. Statistical analysis. The nominal data was compared by using the chi-square test, while for continuous data, The unpaired student t-test was used. Baseline serum concentration of TPO antibody and TSH underwent normality testing using the Crystal Wallace test, and the multivariate logistic regression analysis was comparing the treated subclinical or overt hypothyroid with euthyroid women for the outcomes of failure to conceive and live birth rate of greater than equal to 34 weeks. Results: out of 940 TPO antibody positive participants that were taken, 7.4%, that is 70 patients, developed hypothyroidism, and out of that 63 were subclinical hypothyroid and 7 were overt hypothyroid. 19 patients developed thyrotoxicosis, 18 in the preconception period and 1 in the first trimester of pregnancy. Total 89 patients developed thyroid dysfunction, and out of that 74 patients developed thyroid dysfunction in the preconception period, and out of 74, 71 patients developed in the first 6 months itself. In pregnancy, majority of patients, that is 13 patients, developed thyroid dysfunction at 6 to 8 weeks, while 2 patients developed thyroid dysfunction at 16 to 18 weeks. Out of the 63 subclinical hypothyroid patients, 20 patients didn't get any treatment because they were within the normal ranges according to their local institute. Thyroid test LT4 in the thyroid test abnormalities in LT4 and placebo group. 7 patients developed the overt hypothyroidism, all in the placebo group. 6 patients out of those 7 developed in the preconception period, that is during the first 6 months, and 1 in pregnancy, that is during 6 to 18 weeks of gestation. Those taking levothyroxine were less likely to develop hypothyroidism as compared to the placebo group. 27 seen in the levothyroxine group versus 43 seen in the placebo group. 18 patients developed thyrotoxicosis, and out of that 17 patients were there in the levothyroxine group, and out of those 17, 16 patients developed it during the preconception period and 1 at the 6 to 8 weeks of gestation, and 1 patient in placebo group who developed in the preconception period. Baseline characteristics of those who developed hypothyroidism and those who remained euthyroid. Baseline TSH was higher in those who developed hypothyroidism, that is subclinical or overt, versus those who remained euthyroid. It was 3 milli-international unit per liter in the patients who developed hypothyroidism versus 2 in the patients who remained euthyroid, with a significant p-value. Same was seen with TPO antibody titers, which were higher in those who developed hypothyroidism. It was 213 versus 182 with a significant p-value. No statistically significant differences were noted in any other baseline characteristics. Subgroup analysis of TPO antibody positive women with treated and untreated hypothyroidism. The untreated subclinical hypothyroid and treated subclinical hypothyroid patient had significantly higher rates of failure to conceive when compared with those who remained euthyroid. The live birth rate of greater than equal to 34 weeks, it was seen as 44% versus 38% for treated versus those who remained euthyroid. And untreated versus treated hypothyroidism, the live birth rate was 15% versus 44%. Comparison of maternal and neonatal outcomes between the treated hypothyroidism and those who remained euthyroid. There was no statistically significant differences seen in maternal or neonatal outcomes or complications. Higher risk of preterm birth was seen in the treated subclinical or overt hypothyroid group as compared to the ones who remained euthyroid. The relative risk was 2.27 with a significant p-value. The sample size of the treated subclinical hypothyroid group was insufficient for the meaningful analysis of this preterm birth. Discussion. The starting levothyroxine 15 microgram oral dose, OD dose, while the patient were euthyroid, there was a 40% risk reduction that was observed in developing overt or subclinical hypothyroidism. 19 cases of thyrotoxicosis were seen, mostly in the levothyroxine group, that is 18 in the levothyroxine group, only one that was seen in the placebo group. Any thyroid dysfunction due to the TPO antibody or levothyroxine was seen more in the preconception period or in the first half of pregnancy. Higher baseline TSH values were seen in those who developed overt or subclinical hypothyroidism. High rate of failure to conceive was seen in both treated as well as untreated hypothyroidism. Starting levothyroxine 50 microgram in euthyroid TPO antibody positive may not prevent the development of subclinical hypothyroidism. The likely etiology of thyrotoxicosis in this study was iatrogenic hyperthyroxanemia, as majority of patients developed it preconceptionally. So the role of pregnancy in developing thyrotoxicosis is not there in this study. This finding demonstrates risk of over-treating euthyroid patients even with low dose of levothyroxine. Current literature reported the rate of progression to hypothyroidism as 3 to 41.67% versus it was 7.4% that was seen in this study. The difference may be due to the levothyroxine therapy given in half of the cohort and relatively younger age group. The treated TPO antibody positive subclinical or overt hypothyroid patients had comparable pregnancy outcomes to the euthyroid women. As seen in the tablet trial, there was no benefit with giving levothyroxine therapy in improving the birth rate for TPO antibody positive women. This study also shows that overall TPO, giving the levothyroxine therapy, there was no improvement in the, there was no differences that was seen in the maternal or neonatal outcomes. High maternal free thyroxine concentrations can lead to lower child IQ, lower gray matter and cortex volume, higher risk of attention deficit hyperactive disorder and autistic traits. High free thyroxine concentrations at the higher end of normal in women with thyroid disease can also lead to low birth weight, even with normal TSH concentrations. The weaknesses of this study were that the initial randomization advantage of the tablet trial was lost in this study as the patients developed hypothyroidism. And as there was small events, it can be falsely positive or negative, results in the exploration of baseline characteristics and pregnancy outcomes. The study was insufficiently powered, and there was underestimation of hypothyroidism as half of the cohort received levothyroxine therapy. Strengths of the study were that it was the first study to assess the thyroid dysfunction development both pre-conception and during pregnancy. In pre-pregnancy, euthyroid TPO antibody positive women with a history of miscarriage or subfertility. The data was prospectively collected and it was a large, high quality randomized control trial. Conclusion. The implications for practice that was jotted from this study were that there should be frequent monitoring of TPO antibody positive women with normal thyroid function test within 6 months of pre-conception. And there is importance of early measurement of thyroid profile in first trimester. The analysis of its diagnostic test accuracy should be conducted in a larger cohort study to gain some more insights. Thank you.
I think it's time now for, I think, quiz.
Sir, if there are any discussions.
There are two questions in the question answer, if you can take that. First question is, any incidence of isolated T3 hypothyroidism and how to suspect, and the specific symptoms and signs and how to treat? So the audience is asking that, is there any use of low T3 and any use of this T3 in overall hypothyroidism is different. I think when we are discussing about pregnancy, we can discuss that point first. Yeah, you can take that, Dr. Tharu.
Yeah. So, Dr. Taru, you answer this question.
In this study, they have not mentioned about any incidence of isolated T3 hypothyroidism. Actually, they have not measured. I think Dr. Taru got logged.
I think she got logged out.
But should we wait for her to log back in? I think she's back already.
Yeah, she's there. Yeah, she's come, but I don't think she's logged out, I think. I don't know.
No, she's there. I'll ask her to.
Now she's come. Yeah, yeah, Dr. Taru, you can take that question. Yeah.
Yes, ma'am. Actually, in this study, they have not taken into consideration the FT3 or total T3. They have only measured the total FT4 and TSH values. So, about the isolated T3 values, they have not mentioned in the study.
Dr. Taru, one can look into their supplementary data of this study. Just look into the article. It's a good idea to look for what was T3 values. And authors can be asked to reanalyze their data in context of this point. You know, they must be having some data of T3 also. Definitely T3 estimations are not very precise, but their methodology was comparable with different suppliers' kits. So it's good idea to look into T3 values also in their supplementary data. They must have definitely submit supplementary data, or this Birmingham group can be asked to look into it. Actually, incidentally, I had been to Birmingham just last week because my son is doing fellowship endocrinology in that region only, in the New Cross Hospital. So I think he also participated in this study. One of his center was also there, New Cross Hospital. So even I can ask him to ask his consultant to look into this part. I think a very important point, because FT3 is not the direct action. Basically, it is T3 which is ultimately acting. So very good point. Yeah.
Yeah.
And
so we
also,
can look.
sir, if there is isolated FT3 low also, then there is no need to treat it. If isolated
As
FT3
of
is
now,
low,
the evidence is, we don't have the evidence that T3 is needed separately in pregnancy because the T4 only is converted. So we have to not target T3. But we don't know in this study, maybe as Dr. Sandeep is telling, it's a good idea to see what exactly was the correlation. But overall, whatever evidence we have till now is only that T4 gets converted to T3. Dr. Prasanna wants to add. Dr. Prasanna, please.
Now, basically, we should try to understand that the objective of this study is different. We are trying to see whether antibody positivity and the preconception T3, T4 level. We should look at primary objective. Let us not bring T3 and then try to, because that is not the objective at all.
Yeah.
And there are few flaws, this is a very well conducted RCT. You may say there are slightly, but there are equal number of points. And what is the take-home point for a clinician? You are trying to over-treat thyroid antibody present. And there is no reason euthyroid patient with anti-TPO antibody treating, there is no benefit. So even if you take 2-3 messages out of it and over-diagnosing, over-treating is not going to be any benefit. We should only take those points and then say this is good. Even if you do subset analysis, as Dr. Pramila said, T3, all these studies have shown is useless. They wanted to take T4 and again they said higher level of T4 in normal range has got a problem, right? And many of them developed problems even before conception. Whether it improved the pregnancy rate, whether it worsened the outcome. So taking only those points, what you summarize, very good, I think, study, very well presented. We should take only few points out of it. And then maybe further studies are done. But this is unique study, which is very, very clinically important. And for gynecologists also, endocrinologists.
Absolutely. Thanks, Dr. Prasanna. So, Dr. Taru, there's one more question which we all know, but for the benefit of the audience, you can answer that is there any use of steroids for TPO antibody positivity? So that's the question from the audience. We can take up that
according
question.
to the ATA guidelines also, the recent ATA guidelines also, there is no any indication for the treatment of TPO antibody positive state with steroids. even if TPO antibody positive state and euthyroid status is also there, then also there is no indication for treatment with levothyroxine also. So steroids so definitely are not indicated for the treatment of TPO antibody positive state.
Unless we are suspecting Hashimoto's encephalopathy, which is a different scenario in itself. So that's the only indication where you would be thinking about steroids. Except that there is no other indication anywhere to treat TPO antibody positivity, just for the reason for fertility or anything. There is no study which has shown any benefit. Absolutely. So I think we have one more question. They have the anonymous attendee has asked this question. So they are asking that according to the ETA guidelines, we are starting thyroid supplements for TPO positive with TSH more than 2.5. So what is the reason behind that? So that's the last question we have for this session.
Actually, for the TPO positive status, if the TSH values are above the normal specific ranges for this pregnancy, first trimester, usually we consider the upper range for TSH as 2.5. So if it is above 2.5, then we have to treat according to the ATA guidelines also. So that's why 2.5 is taken as the upper reference range for first trimester. So then we have to treat.
I also see Dr. Neeraj, would like to add to this controversial answer.
Yeah, with the advent of this controversy of should we treat, should we not, what will happen to the child, what will be the IQ, and should we abort, or should we continue with the thing? So many questions to be answered for the pregnant lady. So we better follow the guidelines, and as the guidelines have found out that 2.5 and TPO positivity, we should treat. So that is the basic motto for everybody right now. So we are treating those cases.
Dr. Santosh, your point of view? Because this is a little bit of a controversial topic still.
So we have to remember that treating with levothyroxine is a very expensive proposition in the Western countries. In India, luckily we have it in the essential drug list right now, and we can give the benefit of doubt. I don't think we should, try to break our heads in trying to find out what should be good or what shouldn't be good. So
Right.
as data is saying that about 2.5 you treat, we should treat, especially if the antibodies are positive.
So the message is that the TPO antibody is positive and the TSH is between that doubtful range of 2.5 to 4, we still treat. If it's a bad obstetric history, then again we treat. But in case it's a normal primey with no previous bad obstetric history, TPO negative, then 2.5 to 4 may come in a controversial range. But all the other cases, we mostly treat. Till now, the evidence what we have, giving a low dose is not going to cause any harm. So we can treat these patients who are TPO positive between TSH 2.5 to 4 as well. So that's what we follow at the moment. Once we get more evidence like this study and some more data comes up, we may be in a better position to answer. Till that time, this is what we are following. So shall we move on to the next, Dr. Ganvi? I think we have finished the questions.
Yeah. There are two more things.
One more question, is it? Yeah, there is one more question. This is the same thing. They have it's a continuation of that. I think this is advised before conception, coming with infertility. So we all agree with that between the bad obstetric history, TPO positivity, 2.5 to 4 we treat. So the other garden variety, we might have to debate and see 2.5 to 4, but it's better to err on the side of a mild treatment rather than not treating. This is what we go with. So I think these questions are done. So we can move ahead, I think.
Yes. So thank you, Dr. Taro, for a very explicit presentation. Thank you, Dr. Sandeep sir, Dr. Neeraj Agarwal sir, Dr. Santosh sir, and Dr. Pramida ma'am for a very insightful discussion. So moving on, IT team, can we have? Yeah. So we have the upcoming conference or annual conference of the Indian Thyroid Society, that is the ITSCON 2023, which is being held at Kochi on 27th and 28th of May. So we have also the thyroid ultrasound workshop on May 26th by Dr. Susan Mandal ma'am and Dr. Krishna Sheshadri sir. Also, we have a symposium on recent advances in thyroid cancer by Dr. Vagesh Iyer sir, Dr. Sadish Kumar sir, Dr. Pinaki Datta sir, and Dr. Roma Pradam madam on 28th of May. And on 27th of May, there is a very interesting panel. There are two interesting panel discussions on perioperative management of thyrotoxic patient, as well as postoperative hypocalcemia, how to predict, prevent, and treat. And we also have a quiz which will be conducted both on 27th and 28th of May, and very attractive prizes for the quiz winners. So with that, we will move on. Now coming to the most awaited session, that is the quiz. So we have Dr. Santosh sir with us to conduct the quiz. So I request Dr. Neeraj Agarwal sir to introduce our quiz master.
I have a privilege of welcoming Dr. R. Santosh. He is a very promising endocrinologist. He is a consultant endocrinologist at Magna Centers for Obesity, Diabetes and Endocrinology, Hyderabad unit. And he is also visiting endocrinologist at Fernandez Hospital, Hyderabad, and Apollo Hospitals, Hyderabad. He has very good credentials of being DM endocrinology, FIAMS, and FACE, and he is well published, like 45 publications, including 4 textbook chapters. He is recipient of Abdul Kalam Award for Excellence in Field of Endocrinology. He has been the Endocrine Society of India Conference 2023 organizer, and he is invited as a faculty speaker in international conferences, thus far 8. So we feel that he may have been invited and will be invited in further more conferences because of his virtues and his knowledge. So I welcome Dr. Santosh for his presentation for the quiz.
So shall we have the IT team who's going to present the quiz slides?
Yes, sir. But we will just have a quick run through regarding the quiz participation rules, sir. Once. So to participate in the quiz, having a Zoom app on your mobile device or laptop is essential. You're requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There'll be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or description of the quiz by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz, and all the 10 questions will be available when the poll is launched, and answer for all the questions will be submitted at the end of 10 minutes. To read the case or description, you can close the polls option using the X button and again use the polls option to answer the respective question. So IT team, can we have the dummy questions, please?
Yes, there are 2 dummy questions. So for everyone to get acquainted with the system, we have placed 2 dummy questions. So I will be launching the poll for these 2 dummy questions first. And once we are done with those 2 dummy questions, that is when we will actually begin with the quiz. So we are launching now the dummy questions. Yes, you can now answer. I hope everybody is able to see the questions on their screen. Yes, we already have people answering.
In which city is Taj Mahal located? Option A, Chennai. Option B, Mumbai. Option C, Agra. And option D, Bangalore. So the second dummy question is, how many oceans are there? Option A, 8. Option B, 5. Option C, 6. And option D, 7. I hope all the participants could log in their answers. So now we'll be starting with the actual quiz. Over to Santosh sir.
Okay, so we'll be beginning the actual quiz now. So Dr. Santosh Kumar, can I launch the quiz? Dr. Kumar, can you hear me? Okay, I am going to launch the actual quiz now.
Yes, please do that.
Yes, so the timing for the quiz is about 10 minutes. So it is 8:38 now. And as we launch and end the quiz will be at 8:48.
Right.
I've launched the quiz. I hope everybody can see the questions on their screen. For those using laptops or cell phones, please keep scrolling down to see the next questions. You may be able to see only one question right now on your screen. To see the next question, please scroll down. So you will be able to see all the questions.
Okay. So I shall start right now. I'll be asking the questions one by one. And as I said, please try to answer all the questions within time, because after 10 minutes, it will be closed. So the first question is, all of the following statements has been recommended by the Indian Thyroid Guidelines for Pregnancy. This has been published in Thyroid Research and Practice in 2021, except first option is Indian pregnant women should ingest approximately 250 mcg of iodine daily. Salt intake consisting of minimum 250 mcg iodine daily should be consumed by pregnant women. In India, we have a universal iodination program, and that is a very robust way of delivering the 250 microgram of iodine. So all women should be encouraged to take this iodized salt only. And those patients who are taking regular LT4 supplementation, they can be exempted from supplemental iodine. So I'll just wait for around 10 seconds so that you can think about it and poll, and then I'll go to the next question. Right. The first 3-4 questions I've put quite simple ones so that everybody scores good marks here. Later on will be a little more difficult, okay? So second question is, which of the following infections are not a routine cause of subacute thyroiditis? Option A being Coxsackie virus infections. Option B being pneumococcal infections, COVID-19 and HIV. So please use your time to answer this particular question. Coxsackie, pneumococcal, COVID-19 and HIV. Okay. Now we go to a little bit of pathology. It's something which I used to always not do good at. So which of the following is not typical for Graves' disease? Pathology, okay? Hyperplasia of follicles, scalloping of colloid, extensive mononuclear infiltrate in the thyroid parenchyma, and irregular follicles. The next question is, which thyroid carcinoma has the worst prognosis? Okay, so we have given 4 choices here. Option A is anaplastic has the worst prognosis, followed by medullary, followed by follicular, and followed by papillary. Second option is medullary is the worst, followed by anaplastic, followed by follicular, or followed by papillary. Third option is anaplastic is the worst, followed by follicular, followed by papillary, whereas medullary does not have such a bad prognosis. And the last one is anaplastic is worse than medullary, which is worse than papillary, which is worse than follicular. Okay. Next one is very nice. I found it anecdotal and I found it very nice. So this, let's see how many of you can actually answer this, okay? So thyroid gland, back in 1600s, actually, somebody has first looked at the thyroid gland and decided, not even in 1600s, in 1500s. So I named it thyroid gland at that time. Now, why did they name it thyroid gland? Because A, The two lobes of the thyroid are exact triangles, is it not? So that's why it is called as thyroid. And that's why it was named as thyroid. The second choice is it already looked similar to something called as thyroid cartilage, which was already named. So that's why it was called thyroid. Third, it was the third gland to be discovered. So the first gland was the pancreas, the second gland was in fact the adrenal gland, and third one was thyroid gland. Therefore, it was called as thyroid gland. And it was simultaneously discovered by three scientists. The three scientists have discovered the gland, and therefore they decided to call it as thyroid. The next question being is, who is known as the Nestor of thyroidology? The Nestor of thyroidology. Okay, so we have four names here: James Graves, David Marine, Plummer, and Hokaru Hashimoto. So who is known as the Nestor of thyroidology, and what all did he do? What all work did he do? That's not the answer. You need to just pick up the name over here. Okay. Let's move to the next question. Common complications detected on fetal ultrasound for mothers with hyperthyroidism. So mothers are having hyperthyroidism. You do a fetal ultrasound. You can find any of the following except fetal goiter, congestive cardiac failure, delayed bone maturation, and fetal hydrops. Next is Graves' disease. So Graves' disease in patients with Down syndrome is characterized by. So listen to this question. Graves' disease in patients with Down syndrome is characterized by, okay? Female preponderance, because females, they have more likely to have Down syndrome. So females with Down syndrome are more likely to have Graves' disease. Now we know that Down syndrome patients have a lot of eye-related problems. So Graves' disease with Down syndrome, they have a much increased prevalence of ophthalmopathy. Is that a choice? Down syndrome patients with Graves' disease have severe clinical symptoms. Or the last option is Down syndrome with Graves' disease has decreased rates of remission. So which of the following is true over here? Okay, so the remaining things are false. Only one is a true statement. We come to the penultimate question now. All are classical features of Hashimoto's encephalopathy bar steroid responsive encephalopathy except abnormal EEG, elevated thyroid antibodies, elevated CSF protein or oligoclonal bands, and classic MRI changes in the white matter. And the last question before we close today is, all subtypes of thyroid dysharmoniogenesis are autosomal recessive except SLC26A4 mutation, the DUOX2A mutation, the NIS mutation, or the iodotyrosine dehalogenase mutation. So I wish all the participants all the best. And after the second journal club, we will come back to visit the answers of not only these questions, but also the questions that were released around a couple of days back. So I think with that, I'll hand it over back to the organizers.
Thank you, sir, for a very compelling quiz. So moving on, we have the second journal presentation. I request Dr. Sandeep, sir, to introduce the presenter.
Yeah. So can I have the screen? I think, yeah. So Dr. Supreet, again, he is a doctoral student in Varanasi Institute of Medical Sciences, Department of Endocrinology and Metabolism. And what he's going to present an article that is related to, biochemical inadequate response after initial surgery in patient with medullary carcinoma thyroid, and their follow-up. And this data which is given in this particular study is unique, and it is going to find a very good clinical application, because the only will limited data on the biochemical inadequate response and structural response after initial surgery of medullary carcinoma of thyroid. So a very interesting article. So over to Dr. Supreet.
Sir, can you see my slides, sir?
Yeah, we can see.
Good evening, everybody. My today's journal topic is clinical evolution of sporadic medullary thyroid carcinoma with biochemical incomplete response after initial treatment. Authors are Alessandro Prete and others. This article is from Department of Endocrinology, Pisa University Hospital, Italy, published in JCEM, February 2023. Medullary thyroid carcinoma is a neuroendocrine tumor from the C cells which secrete calcitonin. And from past 2 decades, the incidence has increased. In male, it is about 0.07 to 0.5 per 1 lakh. And in female, it is 0.1 to 0.82 per 1 lakh. Most of the cases are sporadic, which accounts for 75%, and hereditary in 25% cases. Treatment of choice is total thyroidectomy with compartment-oriented lymph node dissection. MTC patient survival is influenced by structural disease, mainly by structural disease that is persistence or recurrence. Dynamic risk stratification model proposed by Lindsay, composed of 3 entities. First one is excellent response, which is defined by negative or undetectable calcitonin level and negative imaging. Second entity is biochemical incomplete response, which is defined by detectable calcitonin level and negative imaging. And third is structural incomplete response, which is defined by positive imaging or biopsy positive patients. Calcitonin is a highly specific marker for medullary thyroid carcinoma, which has been done in this article. And second is carcinoembryonic antigen, which is highly useful in predicting the course of the disease post surgery, which has not been done in this study. Calcitonin and CEA levels over time, particularly doubling time, is or has been recognized as a very important prognostic factor in the monitoring of the patients who has been undergone surgery for medullary thyroid carcinoma. Aim of the study was to evaluate the overall and per site prevalence of structural disease detection during a long-term follow-up in a cohort of 145 consecutive sporadic MTC patient with biochemical incomplete response after the initial surgery. This is a retrospectively evaluated clinical data of 599 consecutive sporadic MTC patients who were surgically treated between 2000 to 2018, and all of them were germline RET mutation negative. Among them, 333 patients had excellent response, 145 patients had a biochemically incomplete response, and 121 patients had structurally incomplete response. calcitonin assay was done by 3 different methods. From Jan 2000 to 2013, it was done by immunoradiometric assay with the assay sensitivity of 2 picogram per ml up to 10 picogram per ml. From 2013 to 2020, CLIA method was used with sensitivity of 2 picogram per ml. And from Jan 2021 till the end of the data collection, that is June 2022, ultra sensitive CLIA method with a sensitivity of 1 picogram per ml was used. Calcitonin stimulation test was done in those who had undetectable calcitonin value. It was done with pentagastrin 0.5 mg per kg IV till 2013, and calcitonin assay was done after 2, 5 and 15 minutes, and with calcium gluconate from 2014 onwards with 2.5 mg per kg of elemental calcium, and calcitonin assay was done after 2, 5 and 10 minutes. Imaging evaluation ultrasound neck was done for the imaging, initial imaging, and if required, PET scan was used for the PET scan, and contrast enhanced CT scan was used for the further imaging. Analysis of red somatic mutation was also done in some of the patients. Mutation analysis in the primary tumor was performed by next generation sequencing. It was done using ION S5 targeted sequencing method with a custom mutational panel that included whole coding region of the red and hotspots in the exons of the other genes involved in thyroid cancer pathogenesis. Statistical data was analyzed by median values and interquartile range. Analysis was performed using SPSS statistics. Mann-Whitney U-test, Pearson chi-square test, univariate and multivariate analysis were performed. Structural detection rate curves and log rank tests were created by Kaplan-Meier analysis. Results. The first graph is showing total number of patients, that is 599. Among them 333 were excellent response patient. Structurally incomplete response were 121, and biochemically incomplete response, which this study included, is 24.2%, that is 145 patients. Graph 2 is for calcitonin assay done by immunoradiometric assay, which comprises of 97 patients, and graph 3 is biochemically incomplete response in 48 patients, and calcitonin assay was done by CLIA method. Prevalence of biochemically incomplete response patient did not differ according to the different assay used for the measurement of serum calcitonin, with 24.6% and 23.4%. Biochemically incomplete response patients followed up for a median of 8.5 years, and structural disease was detected in 64 out of 145 patients, that is 44.1% individuals over time. And the rate of detection was 38% at the end of 5 years and 51.5% at the end of 10 years. And median interval between initial surgery and structural disease detection was 3.3 years. Metastasis, the single site of metastasis was detected or observed in 73.4%, that is 47 out of 64. Most common site was cervical lymph nodes, followed by liver, bone, mediastinal lymph nodes, and lung. Multiple site metastasis was observed in 17 out of 64 patients, that is 26.6%. Most commonly cervical and mediastinal lymph nodes, followed by cervical lymph nodes and lung, followed by cervical lymph nodes and liver, followed by cervical lymph nodes and bone, followed by lymph node, mediastinal lymph node and lung and bone, and lung and liver and bone. Median interval time for metastatic locoregional involvement alone was 2.83 years, and for the distant metastasis alone was 3.50 years, and the difference between the two was not statistically significant. And for the locoregional plus distant metastasis, it was 3.67 years, and the difference between the metastatic locoregional involvement alone and the locoregional plus distant metastasis, there was no significant difference between the two. This table shows epidemiological, pathological, and biochemical data in biochemical incomplete response patient with and without structural disease detection. This table is showing us that structural disease was significantly more frequently detected or associated in male gender, as well as in those who had minimal extension minimal extrathyroidal extension, larger tumor size, lymph node metastasis, and higher staging and more the basal calcitonin levels. They had more chance of having structural disease occurrence. This graph is showing structural detection rate according to the basal values of calcitonin levels. X-axis shows years of follow-up. Y-axis shows structural detection rate. This line is for calcitonin less than 10 picogram per ml. This is for 10 to 50 picogram per ml. This line is for 50 to 150 picogram per ml, and this line is for more than 150 picogram per ml. As we can see, higher the basal calcitonin level, earlier and more frequent was the possibility of detecting structural disease during the follow-up. And structural disease was more frequently detected in patients who had basal higher calcitonin levels, while comparing with the stimulated calcitonin levels. In basal calcitonin levels, structural disease occurrence was 53.3%. And in comparison with the stimulated calcitonin values, it was 20% with a significant difference. And calcitonin doubling time in patients who had structural disease was 26.8 months. And it was compared with the patients who had no structural disease and they had calcitonin doubling time of around 72.9 months. That means doubling time is very important.
Sorry, the slides are not moving,
not
Dr.
moving,
Supreet.
huh?
The slides are just
Slides are
stationary
not
at the
moving.
table. No slides are moving. We are not able to see the slides moving. You're talking about it, but we haven't seen the movement of the slides. It's at table 1. Can you just see the slides are not moving ahead? We are at table 1 only as per the slide.
Just a second.
Maybe you can stop the share and start resharing, then it will move.
Yeah.
Then it will start moving because the slides are not moving at all. You can reshare the slides and start from the table 1 onwards, because from there we were not able to see the slides.
Now can you see my slides, ma'am?
No, it was just showing has started screen sharing. We can see only that much. There's nothing, we can't see the slide. If you're unable to share, the other option is you can send to the IT team, they will share and you can just speak. That is another way of doing it, because otherwise it will be difficult. You can just stop sharing again, try once. Stop sharing and try once more.
Now can you see, ma'am?
No, the slides are not coming on the screen. It's just written has started screen sharing. That is the only thing we can see. If you can do one thing, you can please send it to the IT team or one of us, whichever mail ID you have just now. And from our end, we can share the slides. IT team, can you please help him?
Sure, I'll do that one.
Yeah, please help him. So we can share from your end and he can speak.
Yeah, I am Dr. Chandrasekhar. I'm sending my email ID in the chat. You can mail across your PowerPoint.
In the meanwhile, can we take the questions like till he's doing the sharing, because we can discuss the one of the question is there in the chat box. Dr. Sandeep, can we take the questions in the meanwhile?
I think
Yeah.
did they get the email?
Yeah. IT team, have you got the mail?
Ma'am, not yet.
Mansi, if it's difficult for you, I can share it as well.
You have the slides, Dr. Gandhi?
Yes, no, ma'am. I will ask. You can share it with me, Dr. Supreet, on WhatsApp as well.
Yeah.
You can share it on WhatsApp, no issues. In that group only. We can do it from here, from our end. Dr. Gandhi can do. It's a technical glitch which we can't help it. Technology has its own sets of pros and cons. Dr. Sandeep, till Dr. Supreet is trying to share his slides, can we take some questions? Dr. Neeraj, can we take some questions?
Yeah.
Yeah.
As this study is all about this use of calcitonin. So
Yes.
I was thinking that the study will itself answer his question of
Yes,
using
I know.
calcitonin as a marker of prognosis, and as he is telling that calcitonin was used in the study, and there had been recurrence after incomplete biochemical remission. So that that could answer his question. After this, we completed the.
Right. I think now we have got the slides, so we
Yeah,
can go
I'm
ahead.
also joined now. So I was also lost. So the
Yeah, I
Sandeep
think
Mathur
some
is back
technical
here.
glitch.
Yeah.
Yeah, you can continue, Dr. Supreet,
Dr.
and then we
Supreet,
can
you
take
can
the
continue.
questions.
Yeah.
Till this point, we were able to see the slides. After that, the slides didn't move. Yeah, you can go ahead. Yeah. Dr. Supreet, you can go ahead, please. Yeah.
It's not me sharing it, just a second.
Dr. Supreet, you can share it.
Yeah, Dr. Taru, you can move.
Yeah. You can
Dr.
start
Taru,
with this, Dr. Supreet.
So, yes.
Yeah.
The slide which is showing up, you can start with this.
Actually, it's not, slide is not moving. The next slide I'm not able to.
You don't have to move. It's already there on the screen. You just go on seeing the slides.
You asked the Taru to next.
Yes, sir. Yes, sir.
You don't have to move.
Ganavi ma'am, I have shared with you on the WhatsApp.
No, Dr. Supreet, you don't have to move any of the slides, please. The slides are already there on the screen. You just have to talk. We will do it on from our end. You don't have to do. You just have to say
And
next.
when you finish the slide, you ask next.
The median interval time, that means when metastatic loco-regional involvement alone was taken, the structural disease was found with a median time of 2.83 years, and with the distant metastasis comparison, it was 3.50 years. And the difference was not so much statistically significant. And when it was compared with the loco-regional plus distant metastasis, it was 3.67 years, and it was not so much significant. This table shows us the epidemiological, pathological, and biochemical data in biochemical incomplete response patients with and without structural disease detection. It was found that the structural disease was most commonly associated with the male gender, higher tumor grading, more the tumor size, presence of lymph node metastasis, and more the calcitonin level, more the chance of having structural disease. Next slide, please. In this graph, we can see on the x-axis, it is years of follow-up, and in the y-axis, it is structural detection rate in percentage. And the first line is about calcitonin level below 10. The second line is about 50 to 150 picogram per ml, and the third line is about more than 150 picogram per ml. And it is clearly shown that more the basal calcitonin level, higher the chance and more the frequency was the structural detection disease rate in the patients with MTC. Next slide, please. Structural disease was more commonly associated with those patients having basal calcitonin level compared with the stimulated calcitonin level, 53.3 in those having higher basal calcitonin level and 20% in stimulated calcitonin levels, with a significant statistical difference. And calcitonin doubling time was detected in 26.8 months in those who had structural disease and 72.9 months in those who did not have any structural disease. Next slide, please. This is a univariate analysis to show the association between the risk factors and the occurrence of structural disease. They found that minimal extrathyroidal extension, male gender, and unifocality, lymph node metastasis, and both basal calcitonin and stimulated calcitonin level, they were associated with the higher chance of structurally positive detection with respect to the medullary carcinoma patients. Next slide. In multivariate analysis, only basal calcitonin level 50 to 150 or more and calcitonin doubling time less than 24 months were independently associated with the structural disease occurrence. That means they were having a higher chance of having structural disease when associated with a higher basal calcitonin level and calcitonin doubling time. Next slide, please. In this graph, we can see that in patients who had stage 1, 2, and 3 disease, there was only 8.9% prevalence of having structural disease. And in those who had calcitonin more than 50 to 150, there was a chance of having 80%, more than 80% chance of having structural disease. Next slide. Structural disease management, 36 out of 64 patients who had structurally positive disease. Among them, 36, that is 56.3%, underwent further management. The first treatment was performed at a median time of 4 months. And most of these patients experienced a second surgical treatment for resection of cervical lymph nodes. And 44.4%, that is 16 out of 36 patients, underwent local treatment, that is external beam radiotherapy and bisphosphonate therapy for bone metastasis, or for liver metastasis, it was transarterial embolization. Next slide. During the follow-up, 11 out of 36, that is 30.6%, patients were started on systemic treatment, vandetanib and cabozantinib, and only one patient among 36 reached excellence response after further treatment, while 7 out of 36, that is 19.4%, had biochemically incomplete response, and 28 of 36 patients, that is 77.8%, had structurally incomplete response. And out of 36, 6 patients died of the disease, and the reason has not been mentioned. Next slide. Somatic RET mutations were looked for in 64 out of 145 biochemically incomplete response patients. A sporadic RET mutation was detected in 39 out of 64 patients, that is 60.9%. Most common variant was RET 918 point mutation. Next common was 634, and the least common was 883 mutation. And red positive tumors were more frequently associated with minimal extrathyroidal extension and higher lymph node staging. Next slide. What we already know in the literature was the prevalence of biochemically incomplete response patient, that is 55% and 35% in the literature. In this study, they got 24.2%. And for stage 4 at diagnosis, it was 32.4%. And in other studies, they quoted up to 56 and 25%. And structural disease at 5 years, it was 38.5% and more than 50% in this study, and literature suggests it was 29%. These things we already knew, but in this study they found out that the independent risk factor, that is the staging of the tumor, that is 4A, 4B, and the calcitonin doubling time, they were associated with the risk of having structural disease. But in the literature, they found the many of the risk factors, they were associated with the disease free survival or the prognosis of the patient, not with the structural disease occurrence. Next slide, please. And rest of the things that like minimal extension, extrathyroidal extension, larger tumor size, they were having negative predictive value, and also similar to the literature. The calcitonin doubling time, as already suggested, it represents a independent risk factor for having structural disease. And RET mutation, this also we already know that RET mutation, they will be having an aggressive course in the progression of the disease. Next slide. Strength of the study: larger number of patients consecutively evaluated, and this should minimize the potential bias of the study. And more selective cases, like only sporadic MTC cases, were included. And this study includes the largest number of biochemically incomplete response patients followed up for a long median time. Next slide. Limitations are, this is a retrospective study, and which is one of the most important factor, that is CEA analysis has not been done. It is said that when a patient post-surgery, when a patient is having undetectable calcitonin level and with a positive CEA level, so we definitely have to proceed with the imaging, not to rely on the calcitonin level. Look, that is how much important CEA values are, but that has not been done in this study. Next slide. Quarter of the patient with sporadic MTC show a biochemically incomplete response after initial treatment. Risk of detection of structural disease was around 50% after 10 years of follow-up, with a median detection of 3.3 years. Next slide. And structural disease was more frequently at the level of cervical lymph node, that is, we're talking about metastasis as a single site or in combination with the other metastasis. The predictive factors for structural disease is high value and doubling time of calcitonin are associated with more advanced disease and early progression and early detection of structural disease. Next slide. This algorithm has been proposed by the authors, that is how to follow up and how to monitor and when to get the calcitonin levels post surgery. Usually calcitonin will be normalized 1 week post surgery in those who have calcitonin less than 50. In those who are having calcitonin of 50 to 200 or lymph node positivity, their normalization is usually seen after 4 weeks. And in those who had calcitonin of more than 200 plus the lymph node positivity status, they show normal calcitonin levels or the normalization of the calcitonin level post surgery if it is a successful by around 8 weeks. In this, they propose that basal calcitonin, they divided into two entities. One is stage 1, 2, 3 and second is stage 4. In those with stage 1, 2, 3, calcitonin levels, CEA levels and neck ultrasound has to be done every 9 to 12 months. And if positivity is there, then we have to proceed with the further imaging. And in those with the basal calcitonin 50 to 150, additional CECT or additional image has to be done along with the biochemical and ultrasound test. Those who are having more than 150 picogram per ml, the nuclear imaging has to be done. Those who have stage 4 disease with basal calcitonin 10 to 50 only, we have to consider getting CECT. And after that, it is same for the rest of the patients. Like we have to get a calcitonin CEA ultrasound and the CECT whole body in order to search for the structural recurrence. Thank you.
Yeah. Thank you, Dr. Supreet, for nicely covering up this topic. I think there was one question from audience that what is the importance of calcitonin estimation? I think this whole article has answered that question very nicely. You know, there are two controversial areas. One is when it should be done in every thyroid nodule. That is again controversial. That every thyroid nodule we are not supposed to do calcitonin, and current recommendation does not recommend that. That's an area, a gray area rather. We need more work. But what your study has showed that in prognosis, those particularly those after initial surgery, if calcitonin level is elevated and its pace of elevation, a doubling time, are very important determinant of development of structural disease and subsequent management, including repeat surgery as well as your chemotherapy. So answer comes that in patient calcitonin estimation is very important parameter, not only in diagnosis but prognosis also. So I think let us look for other question.
I think we had only one question. Yeah, that was the only question
but
we
I can
had.
ask you a few questions. Supreet, this article they did actually genotyping and they did for red proton gene. And I think they did not look for severity of disease in context of different genetic polymorphs of red proton gene. Because exome 9, 10, 11, 13, 16, they have different polymorphs and they are associated with different degrees of severity of disease. Did they look into that point in this study or not?
No, sir. Just red positivity, they got bad prognosis and lymph node metastasis and structural disease occurrence was more. But genotyping
so that
and
is, I think, an important limitation of this study. Because if they could have done red proton gene genotyping, and you mentioned they did NGS, if they have done NGS, and they must have at least looked for a panel for a single gene, what I understand. And looking for single gene, even then they should have the data of different exons of this gene, and their polymorphs and their prognosis. I don't know why they missed this finding. I think very important aspect that should be looked into. Because in future, genetic mutation, particularly or somatic mutation, many of the patients who does not have germline mutation, almost 60-65% have actually somatic cell mutation in your tumor tissue. And that is a very important determinant of the severity of the disease and prognosis. So I think that is an important limitation study. I think we have one more question. The study was started from 2000. Have they considered hook effect in previous years? I think they're looking for hook effect in calcitonin estimation.
In the
question for you.
No, sir, they did not mention anything about the hook effect.
Yes, I also remember they did not mention anything about that. But that is an again important point. But is there such an important hook effect in calcitonin estimation?
I think they used CLIA rather than IRMA.
Yeah.
No, majority of the patient radioimmunoassay was used.
No, chemiluminescence assay was used after. So and
a cutoff date, yeah.
CLIA was used.
RIA and subsequently used chemiluminescence assay.
Yeah, initially I think they used IRMA. So that
Yes,
there it is a bit
IRMA,
important because there in IRMA hook effect is important for calcitonin.
Yes.
But calcitonin, for a hook effect, calcitonin has to be in a very high level. And if high level is present, definitely imaging would pickup, like ultrasound will be getting done in every patient. So if the calcitonin level is so much high to cause a hook effect, so we'll be definitely getting under the ultrasound.
You're very right. If it was a very high calcitonin, there should have been a structural disease. And structural disease was not a inclusion criteria in this study, but they consider only biochemical persistent disease and no structural disease. So we don't expect any hook effect in this type of study. Yeah, we don't expect.
So I think these are the only two questions we have. So Dr. Gandhi, we can go ahead with the answers for the quiz.
Thank you, Dr. Supreet, for a very comprehensible presentation. Now, thank you, Dr. Sandeep sir, Dr. Neeraj Agarwal sir, and Dr. Pramila ma'am for a very captivating discussion. And so moving on with the quiz answers. So henceforth, there'll be 2 quizzes which will be conducted for each session. One of them, the way that traditionally the quiz has been conducted, that will be done during the webinar. The other quiz will be conducted prior to the webinar, where there are 5 questions. One question will be released a week prior along with the flyer, and the rest 4 questions will be released a day prior. So we will be giving the certificates for the winners separately for both the quizzes. And I now request Dr. Santosh sir to discuss the answer for both the quizzes and answer the questions. Over to Dr. Santosh.
So, thank you. Can my screen be seen here?
Yeah, we can see.
Yes.
Just you can make it full screen. Yeah. Yeah, we can see now.
So first we'll be discussing the answers of the quiz that have already been, that is a few days back. Okay, the first question that was asked was, which of the following is not a known adverse event of antithyroid medicines? Okay, the options were pruritus, hepatitis, agranulocytosis, and ventricular arrhythmias. So as this quiz was mainly meant for people who are working in medicine, who are working in MBBS. So this was more of simple type of questions. So I'm sure the people who are already doing like endocrinology fellowships, like who are doing DM or DNB, might find this a little bit easier, but it's good to know the answers of all of them as well. So the answer over here is antithyroid medicines. We need to be clear that pruritus is one of the commonest adverse events of antithyroid medicines. And when we follow up these patients, we almost always need to do an LFT and a CBP, because agranulocytosis and hepatitis are very common adverse events. Not very common, they are serious adverse events of antithyroid medicines, leaving the answer for this question as ventricular arrhythmias, which have not been reported with any of the antithyroid medicines. The next question was, only doing a TSH is not beneficial in the monitoring of treatment of which conditions? So you must realize that TSH is a very sensitive marker for the diagnosis and treatment of thyroid related disorders, except in certain conditions. So for early follow of hypothyroidism, you can jolly well do only a TSH and ask the patient to follow up. Hypothyroidism in pregnancy, as it has been already discussed today, TSH is the marquee marker for following up. Hypothyroidism in children also, we need to do a TSH only for follow-up. But please remember that in the early follow-up of hyperthyroidism, TSH is not a good marker, because TSH might take up to 6 months also to normalize in case when you are treating hyperthyroidism. It's mainly the T3 and T4 that needs to be followed up while we are treating the early stages of hyperthyroidism. Do a TSH, but don't expect the TSH to improve quickly. TSH might take up to 5 to 6 months also to normalize in case of hyperthyroidism. The next question that was released a few days back was a 53-year-old lady. She was admitted in the ICU with urosepsis. She had been operated for craniopharyngioma in the past, and she was on regular doses of LT4 100 mcg daily. Her TSH report came to be as 0.001. What will you do to the dose of LT4? So common thing that most physicians or other people would do is, since her TSH is very low, we would like to reduce or stop the thyroid. Both of them are wrong answers in this particular case. You don't stop or you don't reduce the dose of LT4. If you look at option number C, it says that she is sick and she is admitted to the ICU. So this may be a false reading. Repeat a TSH after 1 or 2 days and then decide what to do. Okay, this might not be a wrong answer in other cases, but for this cases, this is not true, because remember that she is having a history of craniopharyngioma in the past. Craniopharyngioma and surgery has been done. So we are expecting the pituitary to be damaged to a certain extent. And in this patient, even if you keep repeating her TSH again and again, even if she's totally fine, it will come normal only. The best thing to do is to send a referral to the endocrinologist. Endocrinologist will come and interpret this. You must do a free T3, free T4, and depending upon the sick euthyroid status, the endocrinologist will decide what to do with the LT4. So you must do a certain other tests. TSH will not be helping in following up this particular patient. T3 and T4 will be probably a better parameter for judging what to do with the LT4 doses. So do some other test is the correct answer. The next question that was released a few days back was a 43-year-old obese lady. Her BMI is 31. She has been following up with you regularly for hypothyroidism. In spite of increasing the doses of LT4 gradually up to 225, her TSH continues to be at 23. All of the following may be kept as a likely possibility in her, except assay interference, which is definitely possible in this particular case, Cushing syndrome, pituitary gland hyperplasia, and compliance issues. So pituitary gland hyperplasia is one of the most troublesome parts of treatment of hypothyroidism. When there is pituitary gland hyperplasia, the TSH does not come down quickly until you give very high doses of LT4. Compliance issues are very, very common, is it not? So people who are supposed to be taking 225, but they are taking it only 3 to 4 days in a week, TSH will never come down. So assay interference, pituitary gland hyperplasia, and compliance issues seem to be the correct answer here, leaving the only wrong answer as Cushing syndrome. Cushing syndrome, isolated Cushing syndrome will never present with a high TSH. In fact, the TSH will be quite low in patients with very high cortisol. The last question that was released a day before was hypothyroid children can present with all of the following except. Answer: delayed puberty, or is it early isolated menarche? Is it early isolated pubarche, or is it early isolated thalarche? So remember, hypothyroid children is in fact the commonest presentation for them is delayed puberty. But in many cases, they can present it with gonadotropin independent precocious puberty, mainly in the form of isolated menarche. So this is called as the Von Wijk-Grimbach syndrome. They can present with menarche actually. Isolated pubarche, that means they don't have menarche, but they're having pubarche, can occur because these girls have a tendency for developing hyperandrogenemia, especially from the adrenals, and because of the changes in the sex hormone binding globulin. Leaving the answer for this question is early isolated thalarche in cases of hypothyroidism is almost never seen. So isolated thalarche, so hypothyroid cannot be the diagnosis. You must look for certain other diagnoses as well. So I think with that, I'll close this PowerPoint slide, which was the questions that were there before. So Dr. Ganvi, do we actually tell the winners over here, or shall we wait for the next quiz questions and then decide?
So can we discuss the next set of questions as well, and then announce the winners together?
All right. So just give me a moment. Okay, so now we have come to the main quiz. So before we come to the main quiz, I would like to, is it visible now in the PowerPoint mode?
So no, it's not in the PowerPoint. Yes, sir.
Yeah, now it is full screen. We can see now. Yeah.
So as I was being introduced, I was mentioned as a organizing secretary of ESICON 2023 in Hyderabad. 2023 is this year. So I am still the organizing secretary. I wish all of you who are listening here to please block these dates and be present at the city of Hyderabad, because this is going to be a scientific feast. Let's go ahead with our primary agenda. Our primary agenda here is the first question. All of the following statements has been recommended by the Indian Thyroid Guidelines for pregnancy, except the answer over here is Universal iodination is a robust way of delivering 250 microgram of iodine. That is wrong, because the universal iodination at the level of consumer can give at the most 120 to 150 microgram of iodine only. Therefore, universal consuming iodized salt only is not a good way of getting enough iodine in a pregnant woman. So you must find out other ways where we can increase the iodine intake. So this is what is given in the guidelines. So remember, iodized salt alone is not enough for getting enough iodine during pregnancy. The infections not being a routine cause of subacute thyroiditis. Remember, routinely, subacute thyroiditis is caused by viral infections only. So Coxsackie virus infections, HIV, were the commonest causes of subacute thyroiditis till we came with this pandemic of COVID-19. As many of our endocrinologists and students would have realized that after COVID-19, many cases of acute thyroid, subacute thyroiditis, which were not explained otherwise, were now ascribed to COVID-19, leaving the answer as pneumococcal infections. Bacterial infections very, very, very rarely only will cause subacute thyroiditis. Which of the following is not typical for Graves' disease? The answer over here is extensive mononuclear infiltrate in the thyroid parenchyma. Extensive mononuclear infiltrate in the thyroid parenchyma is more classical for Hashimoto's thyroiditis. So mononuclear infiltrates do not come into the thyroid parenchyma, whereas paradoxically, mononuclear infiltrate may be seen in the fibroblasts, orbital fibroblasts, which contributes to Graves' eye disease or thyroid eye disease, not in the thyroid. Mononuclear infiltrate is not seen. Which thyroid carcinoma has the worst prognosis? I hope all the students have got this one correct. Anaplastic, the answer is A. Anaplastic, if you know, only 25 to 30% of people will actually survive at the end of 10 years. Medullary thyroid carcinoma, the survival rate is only around 50 to 60% at the end of 10 years. Follicular thyroid carcinoma, because of its tendency to metastasize to different parts of the body, has but good treatment with radioiodine. Almost 94% of patients will actually survive after 10 years. Whereas papillary thyroid carcinoma is one of the best prognosis as far as thyroid cancers are concerned. In fact, it is the best prognosis as far as all cancers are concerned. Almost 98% survival at the end of 10 years. This is just a fun question which I had put. The thyroid gland was named thyroid not because it looks like a triangle or what was the third gland to be discovered. When they discovered the thyroid gland, they have already described the thyroid cartilage, a shield-shaped cartilage, which is already there in the neck. And that's why the thyroid gland was named after the thyroid cartilage, which was already given a name, basically. So because the cartilage was named thyroid, this gland was also called as thyroid. Who is known as the Nestor of thyroidology? So David Marine, okay, he was there in the 1700s. He described a lot of changes, especially with iodine and thyroid. So he was the first person who knew that iodine is an essential nutrient for the thyroid function. He also described the treatment of Graves' disease with iodine. He also spoke about, supplementing or reducing goiters with very low dose of iodine. And he also spoke about the cruciferous vegetables. So all the things that we tell our patients sometimes is that cabbage, cauliflower, etc. All was actually discovered by, was described by David Marine, and we still follow his statements multiple times in our OPD basis. Common complications detected on fetal ultrasound for mothers with hyperthyroidism include all except delayed bone maturation. So as you know, anybody with hyperthyroid, a mother with hypothyroidism, the fetus usually has advanced bone maturation actually. So the bone maturation does not contribute to the, it does not come same as the gestational age. In fact, it goes ahead. It does not get delayed. Now, this was published in 2019 Thyroid Research and Practice, Graves' disease with Down syndrome. Very, very interesting article because I myself have seen, I have not seen many patients. I have seen around 4 to 5 patients. But whenever I did see the patient after this article came, I got a chance to check everything about it. So Graves' disease in Down syndrome is characterized by an equal sex preponderance. So male and females are equally having Graves' disease, when they are having Down syndrome, there is a very low incidence of ophthalmopathy. And the clinical symptoms are very, very mild in patients who are having Down syndrome and Graves' disease. It is the rate of remission which is a problem. So even though they develop Graves' disease, they do not remit fast. They take a long, prolonged time to remit. That's the problem with Graves' disease and Down syndrome. The answer is D over here. All are classical features of Hashimoto's encephalopathy or steroid responsive encephalopathy, except classical MRI changes in the white matter. So very classically, people say that when you do an MRI in patients with steroid responsive encephalopathy, you will find nothing. There won't be any changes in the MRI. It's mainly a diagnosis of exclusion. You need the EEG, the thyroid antibodies, everything needs to be checked. And then we need to give the steroids for treating. MRI will never show anything. If MRI is actually showing something, we might have to take a neurologist's advice that maybe we are dealing with something else only. And the last question is, all subtypes of thyroid dysharmogenesis are autosomal recessive, except it is the DUOX2A mutation. Okay, it provides the oxygen for the thyroid peroxidase antibodies to work properly. DUOX2, it is the only thyroid dysharmogenesis which is autosomal dominant. So it runs into the family very quickly, actually. So DUOX2A is autosomal dominant. All the other thyroid dysharmogenesis are autosomal recessive. I think with that, I'll stop here, and I am also eagerly waiting for the results.
Dr. Santosh, you can announce.
Okay, so these are the pre-quiz winners, is it not? So the pre-quiz winners,
yes.
yeah, are Dr. Preeta MP, Dr. Amulya Sharma, and Dr. Nilesh. So all three of you, are you here? And if you are, absolutely congratulations. It's a good to see that many people have participated and 3 people have emerged winners. Congratulations from me and from the entire organizing committee. Today's quiz. So today's quiz is Dr. Reshma M has won the first prize. Dr. Neelam Yadav has got the second prize. And Dr. Sri Ramaneni has got the third prize. So congratulations once again. I hope all of you have scored really good points and got good marks in this. So I try to make this quiz a little bit easy, interesting, etc., etc. And it's great to see 3 winners over here. Congratulations once again from my side and from the organizing team.
Thank you, sir, for a very interesting discussion.
Sure.
So
I think we have come to the end of the talk today. And so we had a nice discussion on 2 journal club articles, and we thank Dr. Neeraj Agarwal and Dr. Sandeep Mathur for excellently discussing those 2 journal club articles, and not to forget the 2 students who nicely discussed the 2 articles, Dr. Taru Gupta and Dr. Suprit. And then definitely always the highlight is always the quiz. So Dr. R. Santosh took us excellently through the quiz questions and the answers as well. And thanks to him for taking many of the questions from our journal, that is Thyroid Research and Practice. And Dr. Ganvi, who always is there with us to take us through the full sessions. Dr. Sarita Bajaj ma'am is not well today, so she couldn't join us for initial period she joined, but now she is not there with us at the moment because she's not well today. So hopefully she'll be well by tomorrow, and then next session we'll have her with us. And I also just now hand it over to Dr. Ganvi because she'll be telling you about the next thyroid day, which we are organizing through the online session. So Dr. Ganvi will be taking us through that a bit.
So World Thyroid Day is observed on 25th of May, and hence Indian Thyroid Society is conducting a webinar on 25th of May between 7:30 to 9 p.m. So Dr. P.K. Jabbar sir will be the chairperson. We have a panel discussion. Dr. Pramila Kalra madam will be the moderator. So the topic for the panel discussion is management of hyperthyroidism in adults and children. We have both national and international faculty as our panelists. Dr. Syed Abbas Rajpur, Dr. Sharmin Jahan, Dr. Prasad, Dr. Pratosh, and Dr. Sara Alam are all in the panel discussion. So there will be a quiz by Dr. Arpit Kirk, and Dr. Shashank Joshi sir will be delivering a very interesting talk after that. And finally, vote of thanks will be delivered by Dr. Arun sir. So following 25th May, we have the upcoming thyroid clinics again on 14th of June. So Dr. Shanmugh Sundar sir will be the chairperson. Dr. Kripa will be the moderator. We have again a panel discussion on salt iodization, diet, lifestyle and thyroid, very hot topic. So again, we have international faculty with us discussing on this. Dr. Nazmul Qureshi from Bangladesh, Dr. Matiullah Khan from Pakistan, Dr. Santosh from Nepal, and Dr. Manika from Sri Lanka will be the panelists. And again, there will be a quiz by Dr. Ashish Reddy, again followed by the panel discussion. So with this, we conclude today's thyroid clinics. So the upcoming events are after 14th of June, we have the next thyroid clinic on 12th of July, followed by 9th August, 11th October, 8th November, and 6th of December. So with that, we conclude. Thank you all the faculty for participating actively. Thank you, Dr. Neeraj sir, Dr. Sandeep sir, Dr. Pramila ma'am, Dr. Santosh sir, and the two students, Dr. Tarun, as well as Dr. Supreet. So with that, we conclude. Thank you.
Thank you very much. Thank you very much.
Thank you.
Good night, everyone.
Good night.